Good evening, everyone, and welcome to September monthly journal club between BEOS and EOA. Just we have minimal change in the schedule, so Mohamed will start with appraising this paper, delaying anterior cruciate ligament reconstruction for more than 3 or 6 months results in a lower risk of revision surgery. Then Ahmed Ramadan will be appraising another paper in the same topic. So welcome everyone, and let's start. Up to you, Mohammed.
Okay. My voice is clear, Mahmoud, right?
Yeah, we can see your screen. Yeah, just if you
Okay.
want to make it slide mode.
Okay, I will do that. Good evening, everyone. My name is Mohamed Mahmoud. I'm one of the trauma and orthopedic specialty doctor at Warwick Hospital. And this evening, I will be presenting a critical appraisal on an article by title of Delaying Anterior Cruciate Ligament Reconstruction for more than 3 or 6 months results in lower risk of revision surgery. I will try to be systematic as much as I can and will start by just little comment on the journal. So this paper has been published in April 2024 in the Journal of the Orthopedic and Traumatology, which is a formal journal for the Italian Society of Orthopedic and Traumatology. And this has been established like over 2 decades right now. It has very good impact factor and it has open access since 2017. So the impact factor 3.7 last year and around 4 for the 5-year impact factor, and consider like one of the top 14 ranked orthopedic journals. In looking for the research team, we have 3 members, kind of mix between junior researcher, middle like experience, and one of the expert orthopedic surgeon. So Helena, she is a fresh graduate, and I think this is the first paper that she has published, and she participated in the drafting the manuscript of the study and in the statistical analysis as well. Torstein, he is kind of like double qualification. He is a senior physiotherapist with a special interest in the knee and the hip injuries, and he is a very active researcher during his PhD in the soft tissue knee injury. And the most senior member is Professor Martin Lind. He is a senior orthopedic and sport traumatology in Denmark, and he published over 300 paper, which is well known, and all this has added good credibility for the paper. All this stuff working in the same Aarhus University Hospital, which considered at the best in the Denmark and one of the well-known hospital globally, with a specialist in strength in the orthopedic research and in the clinical care. So I think this added some credibility as well, and some trustability in the finding of the results, or on the finding of the article. So starting from the title, again, it's titled Delaying Anterior ACL Reconstruction for more than 3 or 6 months results in low risk of revision surgery. The title here was quite clear. So they identified the intervention, which is the timing of ACL reconstruction, and the comparison time frame, 6 months, 3 months, and 6 months. And they have highlighted the primary outcomes. However, looking for some limitation here, they have used results N, which may give impression that this kind of interventional study, but it's just observational study. I think there was a little bit like not misunderstanding, I would say a little bit confusing term in the title. Moreover, they did not point to the secondary outcomes, which here will be the knee laxity, as I will explain later on. Looking for the introduction. So basically, they're starting by highlighting the clinical dilemma of the optimal type for ACL reconstruction and the historical debate about whether to go for early surgery or delayed surgery, and the finding of having some like stiffness or also fibrosis in the early surgery, or increasing risk of cartilage or meniscal injury in the delayed surgery. They have combined some old and recent studies just to highlight this debatable area. And I think they have identified the importance of lack of consensus on definition of what's early exactly and what's delayed surgery. In addition, they have highlighted the rationale behind the study, and they pointed to the Danish knee ligament reconstruction registry. They have introduced it as the source of the data collection, and they have set a clear aim to investigate whether the delayed ACL reconstruction would affect the revision rate and the knee stability. So just before moving on from the introduction, I think it was quite clear, evidence-based, defining the hypothesis of the study and pointing to the national registry. Maybe it was like stuffed with a lot of literature between the old and the new studies which has been published on the timing of ACL reconstruction. So moving to the methodology, this actually, it was a registry-based retrospective cohort study. They have used the Danish knee ligament reconstruction, covering 13 years, span from July 2005 to December 2018. And the stance here was the large number of the patient. So they have added above or more than 3,000 patients. And just I need to highlight here for the Danish knee ligament registry, which cover all the public and the private hospital in Denmark. And it needs to have uploading from the surgeon and from the patient itself. And it starting by prospective data collection on the patient assessment, on the preoperative and postoperative assessment up to 1 year, and on function assessment. And of course, they add any kind of revision surgery related to the index procedure. Moreover, for the methodology, the exposure was the timing of the surgery, and the group less than or more than 3 months, and the second group was less than or more than 6 months, which was quite clear in the study. And the outcomes from the during the methodology. So the primary outcome was assessing the revision surgery. The primary outcome was assessing the revision surgery at 2 years, and the second outcomes was to assess the knee function, and they have combined subjective and objective knee assessment and patient-related outcomes, which is adding more strength to the study and more credibility to study as well. So looking for the methodology, I think here in terms of the internal validity, the stance was its prospective registry data entry, covering the wide range, public and private sector, and they have very large sample. The weakness here, the study itself, it was retrospective designed, and looking for the measurement of like the knee stability. For example, the pivot shift grating, it wasn't that clear when they have said the methodology about the H group. Moreover, as I mentioned, the study spanned about 13 years, and they did not point to the difference in the surgical techniques or the implant, and they did not consider this in the patient's data collection. So looking for the statistical analysis of the study, the authors compared the revision risk between the early ACL reconstruction, which is defined as less than 3 or 6 months, and the delayed surgery, which is more than 3 or 6 months. They calculated the revision rate with confidence interval, 95%, and compared the risk of using relative risk at 2 years, and the hazard ratios over large follow-up. So the hazard ratios were both unadjusted and adjusted, and they have used Cox regression and Cox regression to study the relationship between the timing and the outcomes of the ACL reconstruction. They have used Kaplan-Meier curves for the survival rate. For the knee stability, they used objective tests. As I said, they used the kilometer and KT 1000, and they have used pivot shift assessment. They have used Q-squared test and patient-reported outcomes. So it's kind of combination of both, and they have used statistical p-value less than 0.05 as statistically significant. The strength here, I think, using the Cox regression to study the relationship between the intervention and the outcomes, and to use or to count some confounding and to both absolute and relative risks. However, we need to just to highlight here that the adjustment was only for measurable values. So they did not consider other confoundings like the rehabilitation, the surgical technique, and the change in the implants all over this 13 years. One more thing, during this assessment, about from 30 to 50% of the patients in both groups, they have missed their patient-related follow-up or knee stability assessment, and this because of some missing in the follow-up, but they still included all this patient in the study. So moving to the results. First, looking for the demographics, as I said, it's including over than 30,000 patients. And we can see that the early surgery group who had ACL reconstruction within the first 3 or 6 months were not really directly comparable to the delayed group. So looking for the results, we'll find that the early patients were typically younger patients, more active, and more likely they had hamstring grafting with less association of like cartilage and meniscal injuries, which is not the same for the delayed group. And looking for the main outcomes, the revision rate was slightly higher in the early group, so 6.8 versus 5.4 in the first group, which is less than 3 months or more than 3 months. And on the other group, it was 6.7 versus 4.9. And here, if we can see that the absolute risk or the hazard ratio, sorry, it's 1.27. In another meaning, we can say that 27% higher in the relative risk of the revision rate in the early surgery. However, the absolute difference would just 1 to 2% high. And actually, we can say this showing a bit of higher revision rate of like just one case revision every like 56 to 71 patients in the early group. And here just I need to point that this is really highlighting the difference in the statistical significant results and in the clinical relevance of these results. So if you have very large sample like this one, any difference between the two groups, it will give you quite significant result statistically, but it doesn't mean that this should be the same importance as a clinical practice. Moving to the knee outcomes assessment. So the objective stability test showed slightly better results in early group. So we can see that 86% versus 82% on the assessment of the sagittal laxity between the two groups. But the difference, again, wasn't clinically meaningful because it just when they assess the both group, just 1 or 2 millimeter different in the assessing of the sagittal laxity. So I think overall the result was quite clear, showing the statistically association between the early ACL and the high revision rate. But the absolute difference was still small, 1 to 2%, and the functional outcomes were essentially not really changed between the two groups, I mean clinically. And again, we need to remember that most of the patients in the early group, they were quite young and active. So for the discussion, the authors like restated the main finding of the study. They acknowledged the confounders like having younger patient in the early group, the graft type which different from every group. They also interpret the second outcomes well, noting that the early patients have slightly better stability. But I think here for the discussions there was some limitations, so the authors are like open about missing data and possibly bias. They did not highlight the missing of some follow-up, which was up to 30 to 50% in some patients, especially for the patient-related outcomes and for the knee stability. Looking for the conclusion of the study, they have just restated again their main finding, and the conclusion was, I think, appropriate. However, we need to be a little bit cautious about the interpretation. Again, for the same problems that I mentioned in the results and the difference between the early and the delay group. So as a final, like criticizing the paper, is it useful? I think it is quite useful. It adds another evidence that the delayed surgery not slightly, showing some decrease in the revision rate. So it's quite useful and added another evidence. Is it reliable? I think yes, it is reliable, but there's some limitation. They did not consider again the having long duration, which was 13 years, and they did not keep it in account. They didn't account the difference in the implant and the improving in the surgical technique. Is it valid? I think the internal validity here is moderate because it's a quite large sample, and they have used the adjusted Cox regression, which improves the confidence. But they did not consider the residual confounding like the rehab, the activity level, and the experience of the surgeon itself. Is it reproducible? Yes, it is, especially if you have similar registry. What's unique about the Danish registry? It has input from the surgeon and from the patient. They have subjective and objective assessment, which is quite good. So if the study would change my practice, I don't think so, because in UK, most of the ACL patients, after having proper assessment, they have their surgery more than 6 months. This mainly because some logistics and the waiting list, and even when you see the patient as acute instance in the knee clinic, usually you send for rehab and to restore the full knee function before proceeding for the ACL reconstruction. So take-home message here, I think the study was well conducted. It depends on large national registry. It has pointed clearly to the primary and the secondary outcomes. There was some limitation, but I think it's all over. It's well conducted. And thank you. Any questions?
Thanks, Ahmed. That's really thorough and very informative. I'm very happy with the structure. The structure is really good. So it's a very well structured appraisal. Guys, if you have any questions, just post it please in the chat, and we'll answer all of them.
Thank you.
So as you mentioned, Mohammed, is already applied in UK, obligatory applied. So yeah, but it's really good in the medical legal. So you can convince your patient that waiting will be in his best interest. It's not only the waiting list and timing, but it's really helpful. So you cannot play with an acute knee. So knee has to get settled completely. That's why the results is better in the delay group. Even the confounding with such a big number of patients, big group, is definitely will be some confounding factor there. So Ahmed is asking, does this study refer to stability trial at all?
So what's the stability trial?
Ahmed? You can unmute yourself, Ahmed. So about the tenodesis.
No.
The stability trial, part 1 is adding the lateral extra-articular tenodesis with the ACL reconstruction for patients with isolated ACL reconstruction in certain categories, like patients under the age of 25 or those patients who are active and are planning to engage in pivoting, shifting, and cutting sports after the surgery. You mentioned that the first group is the young age group, so I would expect them to have LAT reconstruction as well, and this may add more to the risk of stiffness, arthrofibrosis, or risk of revision as an extra limiting factor. So this is a fairly recent study, 2024, so I would have imagined that they must have referred to stability trial or no mention.
They did not mention it at all.
Okay. Maybe because it is a retrospective, so they were studying data from 13 years ago, isn't it?
Exactly, from 2005 till 2018.
Okay, thank you.
Yeah.
And by the way, it just with the stability trial, remember, it resulted in less risk of graft rupture and revision. So even if they, in the last few years, for some reason, when people become more aware of the LAT, I think even if you use this for the younger group, this should have decreased the risk of revision, not the other way around.
I think just Ahmed is pointing about the slightly high risk of fibrosis and stiffness if you do the LTA.
They didn't log in this in the outcomes, yeah? So the main outcomes was revision, yeah?
Exactly. So it's a
The
revision.
primary.
If we assume that the last few years that you were doing LAT for younger patients and they did not comment or they did not mention this, that actually this should should have given this group, the younger group patient, more stability and less risk of revision, not the other way around.
Yeah.
Yeah.
Any more question, guys? Thanks, Mohammed. Yeah, really appreciate it. Ahmed,
Thank you.
can you get your presentation up, please? Ahmed, just stop sharing.
I will stop sharing now.
Ahmed?
Okay.
Yeah, if you just
Hello, everyone.
even up, please.
Okay. Can you see my?
Yeah, I will do. Just you need to make it slide share.
Okay.
Yeah, perfect. Go
Clear.
ahead. Yeah, it is clear.
Hello, everyone. We are going today to do a brief appraisal for this paper. It's a functional outcome in ACL reconstruction, which is a randomized controlled trial comparing all-inside and the transportal technique. I am Ahmed Ramadan. I am a senior clinical fellow in Midstone and Tenerife Wells NHS Trust. So, briefly, the study background. As we all know, ACL injuries are common in young and active population. And this study is comparing two techniques. One of them is all-inside technique, and the other one is transportal technique, which is the routine one without any special instrumentation. They are debating which technique yields better function outcomes. I'm not quite sure if all-inside ACL reconstruction is quite common, so in a couple of slides, I'm going to explain it briefly. All-inside technique, we can see in the left-hand side of the presentation, it's the conventional technique, which is usually take a complete tunnel and bone defect in the tibial side and passing the ACL graft from the complete tunnel towards the knee and then to be fixed in the femoral side. Whatever the fixation technique, could be a biodegradable screw, could be a suspensory fixation. In the right-hand side of the presentation, you can see that all-inside technique is using special instruments to make the two sides of the femoral and tibial sides sockets with the special instruments that I'm going to show you now. They are using what's called flip cutter or several instruments by several companies. This flip cutter is usually presented by Arthrex. It's a matter of wire that is going inside the knee with a special guide. Then it's converted to a retro reamer inside the knee to start the reaming from inside to outside. That's why it's called all-inside ACL reconstruction. So the reaming is usually start, when you look here, is usually start from the tibial side, from inside the knee toward the cortex without violation of the tibial cortex, which is a very important difference between all-inside and transportal technique. This is simply what's called all-inside ACL reconstruction. Back to our paper. It's an original article, has been published in Journal of Orthopaedic Case Reports in November 2024 by a group from All India Institute of Medical Science in Raipur in India. So this is a research type. It's a randomized controlled trial covering 2 years, 12 months of recruitment and 6 months follow-up. Again, it has been done in AIIMS, which is the All India Institute of Medical Science in India, and it's level 2 evidence because it's a small randomized controlled trial. The research question and hypothesis. The questions: do all-inside ACL reconstruction and transporter technique differ in functional outcome? They hypothesized that both techniques yield similar results. So the study population for this paper was a little bit small size, just only 45 patients.
22 one in all-inside group, and 23 patients in the transporter. All of them are between 18 and 45 years old. Majority are young males, 86.7, and students were the largest group of the population for this study. The inclusion criteria are symptomatic ACL insufficiency should be diagnosed clinically and radiologically by MRI scan. Again, age group from 18 to 45 who are willing to consent. The exclusion criteria for this study is multiligamentous injury, any concomitant fracture or infection. Other medical comorbidities that may affect the rehabilitation, including diabetes, hypertension, bleeding, immunosuppressive disorders. Two interventions, as we just mentioned, used in this technique, all-inside technique, again by retrograde drilling, socket creation in both sides from the femur and tibia, and we usually use suspensory fixation as no other options could be used in the all-inside technique. They preserve the gracilis tendon and the less invasive part costlier due to the price of the instruments, special instrument that is used in all-inside technique. Transportal technique is anatomical tunnel drilling via anteromedial portal, which is quite common, and all of us are using this technique. It's technically easier and lower cost due to conventional instrumentation that is used in this transportal technique. They used three outcomes. One of them is the IKDC, International Knee Documentation Committee, which is a questionnaire that's given to the patient. VAS, Visual Analog Scale for pain, again to assess the pain post-operatively, and range of motion, which is the only, I can say, the only objective measure that's used in this study. Other measures, IKDC and VAS score, are subjective, which is a little bit weak point in the research. They assessed preoperative 1, 3, and 6 months only after the surgery, which is another weak point. So regarding the results of the paper, the IKDC score showing both groups are improved significantly over the time till the last point of testing, which is 6 months post-operative, no difference at 6 months. And the early difference usually between first and third month favored the all-inside technique. Regarding the VAS and the range of motion, all-inside technique has less pain at first and second months, which could be explained by that all-inside technique is not doing any violation of the cortices in the femoral and tibial tunnel, and this could explain why the patient usually have less pain. Range of motion is improved in both groups, no significant difference at any time point during the study interval. So the strength of the study are it's a randomized controlled trial design, so higher internal validity. There is clear inclusion and exclusion criteria, regardless the low population of the study. And there is a standardized outcome measures, IKDC, VAS, and range of motion scores. However, I have some reservation that it's an objective, it's a subjective, not objective measurement, except the range of motion. The limitation of the study, it's a small group size, as we just mentioned, just 45 patients, which is underpowered. Very short follow-up. All of us know that the routine rehabilitation for ACL usually take from 9 months to 1 year. So 6 months follow-up looks a very short follow-up, needs to be more tested. It's a single center study, so it depends on the skills of the staff in this study. And it's male dominant cohort, 86.7 are male. It's so limited applicability to females if we use it in female athletes. So the recommendation and the clinical relevance of this study, both all inside and the transportal techniques effective as a long term. All inside technique may reduce pain and speed early rehabilitation. However, at the end of the day, it has the same scores and the same range of motion. Technique shows it depends on the surgeon skills, patient costs, and revision needs. So the research gap in this study is lack of long-term follow-up, just 6 months as the maximum. There is no assessment of return to sport in outcomes, which is quite important in ACL surgeries because most of these patients are usually active at some point. So I think that they need to do an assessment how much of this patient return to doing sports activity. There is no assessment of cost effectiveness in this study, comparing the new instrumentation in the all-inside technique to the transportal technique. And again, limited female representation, so it's just mainly concentrated in the male population. So the conclusion from this study that both all-inside technique and transportal technique yields similar function outcome at 6 months follow-up. All-inside provides an early pain reduction, bone preservation, because it's you just making sockets in both sides. Downsides, it's higher cost for the all-inside technique and the steep learning curve. It takes some time for the surgeon to be aware by the tips and tricks in doing an all-inside ACL reconstruction. Again, it needs for larger multi-center randomized controlled trial with long-term follow-up. Does this change our practice? From my point of view, I think this could give us a clue that both techniques could be used. Both techniques give us a reasonable results, but all-inside techniques needs a little bit higher learning curve to be masterized by the surgeons. That's it. Thank you. Any questions?
Thanks, Ahmed. Very well presented. And yeah, it's quite small sample and a very short follow-up.
Yeah, yeah.
Because they mainly comparing techniques, they don't go so far than this. Ahmed,
Yeah.
I want to come in, so you love knees, so you can come in. So Ahmed's asking, both groups were isolated ACL injury or was any associated injuries?
As an inclusion and exclusion, it's isolated ACL injuries. Any associated injuries were excluded because, as you know, this may affect the rehabilitation and, by the way, the results of the study.
Any more question, guys? So AIMS in India is a very big center. I've been there 2017 for a short visitation. It's a huge center with, yeah.
But again, the sample size for the study was very, it was very short, a very small sample size, just 45 patients. I think if we need to get a more powered study, we need to collect or allocate more patients to get more powered results.
Yeah, the mode of trauma is high trauma, and most of the patients has a multi-ligamentous injury. I've seen, so they can make a much bigger sample, but I think because the inclusion criteria and exclusion criteria, they limited to this 45. But it's a huge center, it's very, very busy. But I think because they're looking into an isolated injury, it could be, that's why the sample is small.
Yeah, that could explain this.
Yeah, it's definitely a start for a bigger, well-formed research to this point. Especially is the cost is a major factor, which make it difficult in different centers, added to the learning curve, of course. Good. Guys, the one thing, general thing is not related to this paper is our presentations are getting better and better. That's something which I'm very happy with. So our presentation is very well formed, structured, goes into clear points. So I think it's very nicely appraised. So Ali is asking laxity comparing surface fixation at the pictures. No, I can read that, Ali. What do you mean? You can unmute yourself and just load this up. Ali?
I can't understand the question, actually.
So Ali, I unmuted him, but Ali, can you just voice this question to us? he will be coming. So I think we're heading the right way. So regular journal club activity from one to the other. I think we're getting better and better. So that's something very assuring. Ali, could you ask the questions because you're unmuted? So if you can ask the question, it will be much easier. So he's asking laxity comparing surface fixation and aperture.
I think that Ali is asking about the suspensory fixation usually in ACL. In some studies, they mentioned that the aperture for tibial and femoral fixation usually could have some widening of the around the graft, could be due to Weber effect of the graft, which is not fixed by screw. Yes, this is the question. That hasn't been addressed in this study, but there is some studies because I did one of these research regarding comparing the techniques of all-inside technique. Yes, there is some evidence that there is some widening of the aperture with the suspensory fixation, but clinically it doesn't have any impact on the outcomes if you thinking about the revision rate and the stability after the ACL reconstruction.
No,
I hope that you got my point, Ali.
Yeah, I think he has a problem in the voice. That's fine.
Yeah.
The answer is clear. Where is the knee, guys? Guys, voice loudly. Any questions about the two papers? So you happy with the messages came in the two papers? So I think, Ahmed, there's no more questions. So thank you so much for that. Really appreciate it.
Thank you, everyone.
Yeah, perfect. You guys, we need to
Okay.
carry on, have a good attendance. You will receive a feedback after that, and Mohamed will be sending you the certificates once he receives the feedback. It's a very important for every one of us in every stage of his career to maintain a regular journal club activity. And thankfully, we were able to maintain this regularly since November. So we're approaching 1 year. So, and we'll give you a very good gift in the anniversary of this. So thank you so much for everyone for attending, and have a good evening. And see you.
Thank you, Mr. Hashem, for your support. Thank you, everyone.
Okay. Good evening, everyone, and see you
Goodbye.
next month.